Just give me a second. Okay. Yes, ma'am. Now we're on live, and everyone can hear us.
Okay. Good evening.
Okay.
Namaskar.
Live. Okay. Okay, ma'am. Just give me a minute. One minute. Okay. Now let's start.
Yeah.
আসসালামু আলাইকুম, শুভেচ্ছা সকলকে। বরাবরের মতোই আজকে আমাদের লাইভ শুরু যাচ্ছে। তো বেসিক্যালি আমরা প্রত্যেক মাসে একটা করে লাইভ করার ট্রাই করি, মাঝে মাঝে ব্যস্ততার কারণে বা অন্যান্য বিভিন্ন ইস্যুর কারণে করা হয় না। শুরুতে ধন্যবাদ দিতে যাচ্ছি আমাদের সম্মানিত ম্যামকে, ক্রিস্টিন ম্যামকে। ম্যাম, থ্যাংক ইউ ফর বিং উইথ আস। অসংখ্য ধন্যবাদ, অ্যাটলিস্ট ম্যামকে ইনভাইট করলে কখন ম্যাম না করেন নাই। তো এটা নিয়ে যে ম্যাম, আমি welcoming you and giving thanks from all of my community. Thank you ma'am again for being with us. আজকে আমাদের টপিক হচ্ছে কিডনি পোস্ট ট্রান্সপ্লান্ট ইনফেকশন এন্ড ইটস প্রিভেনশন। তো এটা খুব একটা ভাইটাল টপিক। অনেকেই আমরা বিভিন্ন ধরনের ইস্যু মানে সন্দিহান, বিশেষ করে বিভিন্ন ভ্যাকসিন, লাইভ ভ্যাকসিন, ইনফ্লুয়েঞ্জা ভ্যাকসিন। আর একটা খুব ইম্পর্টেন্ট টপিক, বিষয় যে শীতকাল চলে আসছে, now it's winter, then we have a chance to get infection, and we have confusion about vaccination, influenza, and further many issues. তো এইসব কারণেই মূলত আজকে লাইভটা নেওয়া এবং ম্যামকে এইখানে ইনভাইট করা। শুরুতে ম্যামকে থ্যাংক ইউ জানিয়ে আমরা লাইভ শুরু করতে যাচ্ছি। আপনারা যে কোনো প্রশ্ন করতে পারেন, এবং আমরা প্রিভিয়াসলি বেশ কিছু কোশ্চেন নিয়েছি। ম্যাম উইল answer them, and ম্যাম থ্যাংক ইউ। Let's start.
Thank you, Rafi. It's always a pleasure to be with you all. So, namaskar, assalamu alaikum to all of you. In continuation with the previous discussions which we have had, today we'll discuss another very important topic, that is post-transplant infections. So we all know that for patients of kidney failure, kidney transplantation is the best form of treatment. And with the newer immunosuppressive regimens we have and the newer surgical techniques, the outcomes have improved significantly. The graft outcome and overall patient outcome. Rafi, is there a disturbance in the background?
No ma'am, it's okay.
Yeah. So the overall outcomes have improved significantly. But still, infections remain a very significant complication, both in the immediate post-transplant period and in the late post-transplant period. So how to tackle these infections is a continuing area of research, and today we will discuss about what are the factors which contribute to infections and what can we do as a transplant community, as transplant recipients and as doctors to prevent infection. So when we talk about transplant infection, there are some factors which decide the time of infection and the type of infection. For example, donor and recipient factors. Some infections can be transmitted from the donor to the recipient, more so in cadaver or deceased donors. Then some infections can be latent, or it can be silent within the recipient's body, and after transplant it can flare up. Other factors like the degree of immunosuppression. Some situations we have to give higher or more stronger induction regimen, and this puts the patient at a higher risk of infections. Or if some patient has had a rejection, let's say in the post-transplant period, and we had to give anti-rejection treatment, even that puts such patients at a higher risk of infection, not just in the immediate post-transplant, but for a prolonged period of time. This is something known as net immunosuppression, or overall level of immunosuppression of the recipient. Then there are other factors like metabolic factors. What is your nutritional status? What is your body's immunity to begin with? Some patients on dialysis, they become very emaciated, they are very much malnourished, and then once they go for transplant, their overall immunity to begin with is low. That also puts them at a higher risk. Diabetes uncontrolled. You are a diabetic, you undergo transplant, your diabetes has been uncontrolled. That also puts you at a higher risk of infections. So these are some of the factors. Then, of course, other social factors, environmental factors also contribute. For example, if you are staying in a place which is overcrowded, you are visited by people who could be carrying infection. And in our country, both India and Bangladesh, we often face this, that once a patient goes out into the community, they are intermingling, there is some level of overcrowding, there is visiting by people who could be carrying infection. So that those are all lot of socio-demographic factors also come into play. Then certain fungal infections which are endemic to certain area, and certain fungal infections like mucormycosis. It has been shown that if there is a construction work going around, it puts you at a higher risk of having this type of fungal infection. So medical factors of the recipient donor, factors related to the drugs, the immunosuppressants you're on, social factors, demographic factors, all these decide your risk of developing infection. Now, what are the infections and when can you get it? So, based on the post-transplant time duration, we divide generally into three groups or three time periods. So, first is the immediate post-transplant. Within the first month of transplant, usually this is a time wherein you are at risk of developing some surgical site infections, urinary tract infections, sometimes pneumonia. And these are some of the common infections which you could get in the post-transplant within 1 month period. And another thing is, if you have a central line, a catheter, you could also develop a catheter-related infection during this period. That is the initial 1 month. Then the next is 1 month to around 6 months. This is also the time wherein the immunosuppression is the maximum. You have the effect of the induction treatment that you have received, whether it is ATG or it is besimumab, the steroid pulses, and then you are on maximum doses of your tacrolimus, MMF, and steroid. This is the 30 days to 6 month period where you are at the peak of immunosuppression. You are at risk of opportunistic infections. Opportunistic infections means they are organisms which usually does not cause disease in immunocompetent people. People with good immunity do not get affected, but you being a transplant recipient at the maximum level of immunosuppression are at risk of these. These include infections, viral infections like CMV, herpes simplex virus, Epstein-Barr virus, and some fungal infections, including Candida. And some of these fungal infections can come in this period. Then there can be PCP pneumonia, again, an opportunistic pathogen which can affect during the 30 days to 6 month period. Another very common infections which we see in our country and our subcontinent is tuberculosis. Again, tuberculosis can come anytime in the post-transplant period. It can happen as soon as the initial 6 months or later also. Then beyond 6 to 12 months, the immunosuppression reaches a baseline or maintenance immunosuppression, that is lower levels of immunosuppression. Then your risk is almost similar to the community, I would say, not exactly similar. You get usually community acquired infections. You still are at higher risk compared to a normal adult, but the infections are usually the community pathogens. Like you can get bacterial pneumonia, you can get viral pneumonias, influenza. Sometimes also some opportunistic infections like PCP, cryptococcal can happen later post-transplant. Again, if you have had any episodes of rejection in between and you have had an anti-rejection treatment, let us say after 6-7 months of transplant, you had a rejection, you received anti-rejection treatment. Again, post-rejection, the initial 3 months is very crucial. You are at higher risk, like how it was after your immediate post-transplant. That is important to understand. After anti-rejection therapy, again you are at higher risk. So this is briefly about the timeline of infections and what infections usually happen. Now, again, another important factor when we talk about infection and infection risk is about cytopenias. Okay, so that is lower WBC count. You would have seen that in immediate after your transplant and later on also, sometimes your WBC counts can go very high or sometimes it can drop very low. So these are again seen because of many of the drugs which we are giving. So leukopenia means low WBC count. So low WBC count itself is a risk for developing infection. So that is why we monitor these counts very closely after the transplant. What is normal? Usually the lower limit of WBC count is 4,000 that most of the labs take. 4 to 10, 11,000. So the lower limit is around 4,000. Anything below 4,000 is considered leukopenia or low WBC count. So 3,000 to 4,000, it is classified as grade 1 leukopenia. If it is below 3,000 up to 2,000 is its grade 2. 1,000 to 2,000 is grade 3, and below 1,000 becomes severe or grade 4 leukopenia. Similarly, we also look at the neutrophil count. WBC count is a total white blood cell count. In that, one component is lymphocyte and another component is neutrophil. So absolute
question.
Yeah, tell me.
Ma'am, one question about WBC. What will happen if it go rise about 13,000, 14,000, 15,000?
Correct. Very good question. So I was talking about low WBC. Similarly, it can go beyond that 10, 11,000 mark. Many times we see patients having 13,000, 14,000 WBC count, but no symptoms. So one common cause that we see is the steroids. The steroids which we give will usually raise the WBC count, which is a normal response in the body. Steroids, whether it is oral steroids or pulse steroids, can increase your WBC count. It is normal response. There is nothing to worry about. So if there is persistent elevated counts, we generally look for any signs of infection or any focus of infection. If everything is fine, you are feeling well, it is only the WBC count which is elevated, you don't have any other symptoms of infection, we just monitor it. If it is persistently high and unexplained, sometimes we do a peripheral smear to see that nothing is abnormal. Okay, peripheral smear to see the type of cells. But as I told, it can happen as a result of steroids, and some people it can persist for longer time, even with smaller dose of steroids. That is commonly seen. Only thing to remember is we have to rule out infection. We have to rule out any underlying infection. Otherwise, total count elevated per se is not a problem. Okay, lower counts, even if asymptomatic, you are feeling very well, but your counts are low, is a problem. Whereas your counts are elevated, you're completely fine. We can monitor. It is not really alarming as such. But if your counts are low, even if you're feeling well, it needs to be closely monitored. If the counts are dropping further, we modify the medicines, which I'll be coming subsequently, okay, to improve the counts. Because if the counts are really low, they are your soldiers. The white blood cells are your soldiers to fight any infection. So if the counts go down, you become highly at risk of developing infection. So that is risky. Okay.
Ma'am, another question. Most of the cases, as far as I've seen, someone looks like when WBC got higher, as well as hemoglobin got higher. And is that professional to hemoglobin level? And is higher hemoglobin level is dangerous for us?
Sorry, higher hemoglobin level
is good for us, like 16, 17,
Correct.
18.
So yes, after transplant, many times we see hemoglobin increase. Okay, it is natural. So during the dialysis phase, of course, there is no erythropoietin being secreted. After transplant, the transplanted kidney secretes a lot of erythropoietin. Hemoglobin improves. But again, there is a condition of post-transplant erythrocytosis. Okay, wherein the hemoglobin goes beyond 15, 16. We see 17, 18. So such high values. The problem is the blood becomes thick when the hemoglobin goes so high. Okay, so that is not good in the long run, because also we are the kidneys connection, the blood vessels, if the blood is thick, blood is flowing, there is a technical risk of blood getting clotted in the blood vessel. So many times we start you on certain medicines to lower the hemoglobin, or if the hemoglobin increases too much, we may have to do a phlebotomy to remove the blood periodically. That also we do. So too much is not good. And whether it correlates elevated hemoglobin and the total WBC, there is no clear cut correlation. Okay, hemoglobin sometimes, like I said, hemoglobin can increase to high level with normal counts. So there is not really a clear cut correlation between the two. But there are situations wherein both can drop. In fact, what I mentioned was WBC dropping. There are situations wherein hemoglobin and WBC can drop. There are situations wherein WBC, hemoglobin, and platelets, all three can drop, which we call as pancytopenia. That means all the three group of cells are reduced. Or it can be bicytopenia, two cell lines, the hemoglobin and the WBC counts are reduced. So there are specific situations, like certain viral infections can cause pancytopenia. Certain viral infections can cause only lymphopenia. Some drugs, like commonly the mycophenolate MMF, which we use, is a myelosuppressant. That means it can have an effect on the bone marrow and suppress the WBC count. Likewise, the ATG which we give, antithymocyte globulin, given during induction or sometimes as a treatment of rejection, can reduce the WBC count, can even reduce the platelet count. Likewise, some of the prophylactic medications which we give to, that is valganciclovir, you must have heard. Initial 3 months we generally give valganciclovir to prevent the CMV infection. It can also reduce the WBC count. Again, cotrimoxazole, the Septran or Bactrim, which we give as a prophylaxis again to prevent infection, can reduce the count. Doesn't happen in every patient, but it can happen in some patients. These are some of the common drugs. Of course, tacrolimus also has an effect on the cell lines, not as much as mycophenolate. MMF is more commonly the drug affecting the WBC count, but tacrolimus is also known to cause neutropenia, that is low neutrophils. Then rituximab is given as sometimes in the induction treatment for ABO incompatible transplant, or in the treatment of ABMR, that is antibody mediated rejection. We use rituximab, and it can have prolonged effects of suppression, especially on the neutrophils. There is something known as late onset neutropenia. You have given rituximab, you see after 3-6 months still the counts are low. That is also described. So yes, some of these medications have effect on the cell counts, putting you at a higher risk. So very close monitoring with your transplant physician becomes very important. That is about cell counts. Okay. And yeah, so till now I have covered about what are the infections, the timeline of infections, what puts you at higher risk of infections. And now we will come to the prevention part. So till now, if you have any doubts, you can ask me in this. We'll go ahead.
Let's go ahead.
Yes. Yeah. So now we have spoken about what are the infections and what are the risk factors. Now, how to prevent? First is a thorough assessment prior to transplant is very important. Assessment of the recipient and donor. The recipient for any occult infections while on dialysis, whether in the recent few weeks he has had any infections, prior tuberculosis history, prior history of fungal infections in the lung. Entire history of infections in detail is to be taken prior to transplant. That is number one. Second is, prior to transplant, again, your overall nutrition status, your diabetic control, all this should be optimized. I always tell my patients that transplant is not something which you do as an emergency. Transplant is always planned. You have to optimize yourself for best outcomes after transplant. Third thing is vaccination. Vaccination should ideally happen much before the transplant. Vaccinations like hepatitis B, pneumococcal, influenza, vaccines should be given prior to transplant. And if it can be given in early stages of CKD, like hepatitis B vaccine should be given before the patient goes into dialysis. If not, at least when the patient is started on dialysis, hepatitis B vaccine should be given. So then again, diabetic control and improving overall nutrition also helps in improving the immunity. All this prior to transplant. Now, around this time of transplant, we plan immunosuppression. So we have to assess the immunological risk depending on who the donor is. Donor is a parent, sibling. The immunological risk is low. Then whether the patient has received any blood transfusions, whether it is a second transplant, all these decide our level of immunosuppression. How much immunosuppression we have to give a patient. Age of the recipient is important. Somebody is elderly, we will not give too much immunosuppression, because if we give too much, they will develop infection. So we assess the overall immunity status, the immunological risk status, prior infection risk, all this to decide on what induction immunosuppression to give. Then of course the tacrolimus, MMF, steroid, then all these are started at different time periods. Monitoring, getting adequate drug levels, close monitoring for side effects of these drugs, and starting the prophylaxis. Prophylaxis is very important. Now I think most of the transplant centers use Valgan cyclovir prophylaxis and Bactrim or Septran, that is cotrimoxazole prophylaxis. Some of the centers also use fluconazole or antifungal prophylaxis as well. This is antimicrobial prophylaxis. Then comes lot of general precaution measures, which of course starts from the day patient is admitted. Most of the all the hospitals, transplant centers follow strict infection control practices. Then once the patient is discharged at home, you have to follow strict hygiene measures, hand washing, masking yourself, avoiding crowded places, eating home cooked food, well cooked food. All these go a very long way in preventing infection. These are simple measures but very effective measures, and this is not for a day or two. It has to be continued religiously forever. So this is your change in your habit, your lifestyle. And while traveling, you have to plan in advance. This is of course after the 6 to 12 months. Whenever you have completed 1 year, you want to travel, you have to plan in advance. You have to avoid too much crowded places, mask yourself, keep yourself away from too much of street food, or food cooked in unhygienic place. All these precautions you have to take. And other important thing is your medications. So medications, you should understand what are the potential adverse effects, and you have to check yourself periodically. This is very important. So usually within the initial 1 to 3 months, we very closely follow up. 2 times in a week we call the patient. Even if everything is going well, we ask them to do the blood test and meet us. This is precisely the reason, because counts can vary, counts can go up, down. Total count suddenly dropping can put them at a risk. There will be no symptoms. So we have to monitor very closely and adjust the medicines accordingly. So if the WBC counts drops too much, we will reduce the MMF. Sometimes we have to stop MMF and things like that. So that is case to case basis. The treating transplant physician, nephrologist, will take a call. Very important to be closely associated with your nephrologist and transplant physician as advised. That is important. Then you have to report in case of any symptoms. So you should not delay. If you get fever, you're getting cough, so it is not like how it was during your CKD days or while you were on dialysis. Post transplant, any signs of infection should not be neglected. You have to consult without delay, so that it can be treated and identified at the early stages itself. Especially in the initial 6 months to 1 year after transplant, very crucial period. Infections can suddenly start, and within hours we have seen that it can become really bad. So you should not neglect any symptom. And of course, treatment wise, that is, we start on antibiotics or antivirals depending on what is the suspected organism. We now have lot of sophisticated testing methodology to diagnose the type of infection and treat. But the important thing remains to pick it up early and modify the immunosuppression. So many times we have to reduce the immunosuppression when an infection happens. So always when an infection happens, we reduce the immunosuppression. There is a risk of rejection. So that is another aspect of it. Whenever there is an infection and we reduce the immunosuppression, there may be a risk of rejection, which we have to balance both out. So this is in brief about how to, identify and prevent infections, general measures. Now coming to vaccination, another very important aspect. As I mentioned
Ma'am,
that
one question.
Yeah.
Infection related rejection, is it make chronic rejection or acute?
So it can be both. It can be both. So sometimes we see that patients, for whatever reason, with severe infections admitted, we have to stop MMF. Sometimes we have to reduce and even stop tacrolimus. And then, so another point is, whenever there is a severe infection, creatinine tends to go up. Acute kidney injury. It need not be rejection always. Patient can be dehydrated, and because of sepsis itself, creatinine can go up. Then it settles down, and then once the patient is stable, we are closely monitoring, then we see creatinine again going up. If we do an early biopsy right there, we can pick up an acute rejection. But sometimes what happens, it doesn't happen like a sudden jump in creatinine. Okay, patient remains stable. On follow-up, slowly creatinine is increasing, slowly protein leak comes up. So this is something like a chronic rejection, chronic ABMR, antibody mediated rejection. Many times when we stop immunosuppression, slowly the antibody starts forming. It will not cause an acute rejection, but it will slowly start damaging the graft, resulting in slowly creeping increase in creatinine. Some proteinuria starts to come in. When we test, if we test, that is, we will be able to pick up the antibodies, donor specific antibodies. So both acute rejections and chronic rejections can happen in this setting. Okay. So moving forward, about vaccination, again another very important aspect, but I would say not very much stressed upon in the post transplant period. In the pre transplant dialysis time is the time where we should start vaccinating. That is number one. And after post transplant, the general principle is that all attenuated and inactivated vaccines are safe, whereas live vaccines should not be given in the post transplant period. And majority of the vaccines are inactivated vaccines, what we use nowadays. Like your influenza vaccine is an inactivated vaccine, and it is now we have guidelines by CDC, and most of the international bodies give guidelines which are the vaccines to be given for post transplant patients. And this includes, one is yearly influenza vaccine, it should be taken. Pneumococcal vaccine. So pneumococcal vaccine, there is a conjugate vaccine and there is a polysaccharide vaccine. What we commonly write is the PCV 13 and PPSV 23. So PCV is a conjugate vaccine, then there is a polysaccharide vaccine. Generally, we try to give both in the pre-transplant period because it is valid for 5 years. Then only after 5 years we have to give a booster. So if not taken during the pre-transplant period, then it should be given in the post-transplant period. Likewise, other vaccines like hepatitis B is an inactivated vaccine which can be given in the post-transplant period. Inactivated and conjugate vaccines also can be given. It is only the live attenuated which should not be given. So hepatitis B, influenza, pneumococcal, and even now we have the shingles vaccine, Shingrix, that is the herpes zoster vaccine, which also can be given in the post-transplant period. Now, when to give in the post-transplant period? So the conjugate and inactivated vaccines are safe to be given, but in the initial 6 months to 1 year period, the level of immunosuppression is high. So even when you give the vaccine, the body will not be able to develop protective antibodies. So generally, it is advised that after the 6 months period is when you can give the vaccines. So again, if you have had any rejection and your immunosuppression is high, so initial post rejection, that 3-month period should be avoided. Excuse me. Once the immunosuppression is in the baseline level is when you can take the vaccine, so that body is able to mount adequate protective antibody response. So flu vaccine should be planned yearly. Around this October, November time is generally when the new strain comes. So you can plan to take it every year. And in fact, it is advisable that the transplant recipient and their close contacts also should take the flu vaccine. That is what the guidelines say. Because if your close contacts develop a flu infection, your likelihood of getting it increases. So that is about vaccines. Okay, and prophylaxis, I mentioned cotrimoxazole prophylaxis prevents not just PCP infection but also urinary tract infections. Urinary tract infections again is a common issue with some transplant patients. So cotrimoxazole prophylaxis 6 months to 1 year we try to give. It does prevent urinary infections and PCP pneumonia. After that, if there is UTI, how to treat? Again, there are guidelines. Some people just do a urine culture shows some growth, but they have no symptoms, whether to treat or not. That is again a whole lot of discussion around it. In the immediate post-transplant period, we tend to treat, but later on, if there are no symptoms, it is just asymptomatic bacteriuria. Many times we don't treat it, we just monitor. So that is just offshoot, another topic which I just remembered. So vaccines I mentioned about drugs to prevent infection, general measures to prevent infection, and very important to have a close watch on your symptoms and be in constant follow-up with your nephrologist. That is again very important, because your counts may fluctuate and it may put you at a higher risk of infections. If you don't test, you will not know. Okay. Anything else, Ravi?
You got stuck. Motor there may have some network issues, ma'am.
Me, is it?
Yes, ma'am.
Oh, am I audible now?
Now you are audible, but you got stuck in the same picture.
Oh. Okay.
But now it's clear. Now it's clear. Please continue.
Yeah, so I was telling, I think I have discussed about infection, the risk factor, what are the general measures, prophylactic antibiotics which can be given, and the importance of monitoring closely and early treatment. Now we can take questions and we can further discuss depending on the questions.
Before taking question, we have a guest, and he's Tamal Shakar. He's eagerly waiting for the last 3 months for your life, and that's why I took him to that stage. And he has some question. Tamal, তুমি তোমার কোশ্চেনগুলো করো, হিন্দিতে করো।
Namaskar, Mr. Sharkar.
Yes, ma'am. Ma'am, I am calling from Siliguri, West Bengal.
Nice. Tell me.
Actually, ma'am, मेरा ट्रांसप्लांट अराउंड 7 years हो गया.
Okay.
तो क्रिएटिन सब कुछ ठीक है, लेकिन अभी 1 साल से मेरा प्रोटीन थोड़ा लीक हो रहा है.
Okay.
तो मैं बायोप्सी किया था.
Okay.
तो मैम बायोप्सी में रिपोर्ट आया है फोकल सेगमेंटल ग्लोमेरुलर सीरियस एनओएस,
ओके
और मेरा मैम क्रिएटिन तो ठीक ही है, और इसका क्या हीमोग्लोबिन भी ठीक है,
ओके
प्लेटलेट ठीक है, और मैम माइक्रो एल्बुमिन और क्रिएटिन रेशियो 2476 है मैम।
अच्छा 2.4 ग्राम है।
हाँ मैम।
ओके
और
ओके
बाकी शुगर ठीक है, शुगर भी कंट्रोल में है।
ओके
ठीक है सर
ओके
मैम। ये सब देख के मेरा जो डॉक्टर है, डॉक्टर प्रतीक दास, आर एन टैगोर,
हाँ
कलकत्ता।
हाँ 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 बहुत सीनियर डॉक्टर है। हाँ जी।
यस मैम। तो उन्होंने मैम हमको जो मेडिसिन दिया था,
हम्म
आपका जार्डियन 10,
हाँ हाँ
जार्डियन 10 दिया था, और मैम कार्डेस दिया था।
हाँ जी सही दिया है, बिल्कुल सही दिया है।
कार्डेस दिया था, और लेकिन कुछ प्रॉब्लम सॉल्व नहीं हो रहा है मैम। फोम यूरिन में बहुत आ रहा है, फोम एक्चुअली, मतलब पूरा फोम आ रहा है, और एनर्जी लेस हो रहा है, कोई भी मतलब एकदम फुल एनर्जी, कोई काम में ना एनर्जी नहीं लगता मैम।
अच्छा अच्छा नहीं, इसमें यही होता है कि हमें मेडिसिन जो कार्डेस और आपको जो दिया गया है ना, उसका डोज हम धीरे धीरे बढ़ाते हैं, है ना, कि जितना आप
राइट मैम।
टॉलरेट कर सके उसको डोज को इंक्रीज करके वो प्रोटीन लीक को कंट्रोल करना पड़ता है। ठीक
राइट
है,
मैम।
तो इसमें इसमें ट्रीटमेंट जो दिया है वो बिल्कुल सही है। बस इसमें आप रेगुलरली डॉक्टर प्रतीक दास से फॉलो अप कीजिए ताकि वो आपका डोज बढ़ा सके। इसमें क्या है ना कि एक डोज में बस शुरू करके हम जनरली नहीं रुक सकते। अगर प्रोटीन लीक जैसे आपका 2.4 ग्राम है तो वो काफी
हाँ मैम।
ज्यादा है ना, वो भी एल्बुमिन 2.4 ग्राम है, तो उसे
राइट मैम।
कंट्रोल करना बहुत जरूरी है। कंट्रोल नहीं किया तो वो आगे जाके वो क्रिएटिन बढ़ना शुरू होगा। तो कंट्रोल करने के लिए यही मेडिसिन है, बस इसका डोज धीरे 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 बढ़ाना पड़ेगा जब तक वो प्रोटीन कंट्रोल में नहीं आता है। ठीक है, तो आप
राइट मैम।
बस डॉक्टर साहब के पास रेगुलरली फॉलो अप कीजिए, क्योंकि जब एकदम से वो बढ़ा नहीं सकते, एकदम बढ़ाएंगे तो क्रिएट बढ़ेगा, धीरे धीरे
राइट मैम।
बढ़ाना पड़ता है। ठीक है, धीरे धीरे बढ़ाने के लिए आप रेगुलरली दिखाएंगे तो वो धीरे धीरे आपका डोज बढ़ाएंगे। ठीक है, उससे प्रोटीन कंट्रोल आएगा।
अच्छा, मैं मैम मतलब मैं आप एक बार चाहते हो कि मैं बेंगलोर में जाके आपका साथ मीट करूं?
नहीं, इतना दूर आपको आने का जरूरत नहीं है। डॉक्टर प्रतीक दास और टैगोर हॉस्पिटल वहां पे बहुत सीनियर नेफ्रोलॉजिस्ट है, आप उधर ही दिखा सकते हैं। हम भी यही ट्रीटमेंट ही देंगे, है ना। इसी को
हाँ
थोड़ा सा
मैम।
एडजस्टमेंट ही होता है, वो आप उसके लिए उतना दूर आने का जरूरत नहीं होगा। ठीक है, आप उधर ही दिखा
ओके मैम।
सकते हैं, वो सब अच्छे डॉक्टर है।
ठीक है, ठीक है, थैंक यू
ठीक है,
मैम, थैंक यू वेरी मच
ओके,
मैम।
टेक केयर, टेक केयर, नमस्कार।
তোমাল তুমি তো লিভ নাও, আমরা কন্টিনিউ করি নাকি?
श्योर श्योर
তুমি
श्योर श्योर श्योर।
তুমি অনলাইনে দেখতে পারো আমাদের পেজে।
ठीक ठीक है, ठीक है, ओके।
তুমি পেজে আসো, হ্যাঁ? ওকে।
Rafi, you're muted.
Sorry.
Yeah.
Okay, ma'am. We have some question. We have first of all, I will take question from Jahid, and he is 3.5 years post transplant. Have T cell mediated rejection and got ATZ. And creatinine is about 2.2 to 2.7 to 2.3 around. And last line, you asked him, as hemoglobin was decreasing, you asked him to take erythropoietin. He is taking oxemia 100 and it's increased hemoglobin now. He is just asking if instead of erythropoietin, is oxemia safe or not?
Yeah, so his creat now is around 2, right?
No, I mean about 2.7 to 2.9.
Okay. Yeah, so oxemia, that is desidustat, it is
Yes,
it has a different mechanism of action,
but it works.
by which
It's working well, ma'am.
yes, it works well. It works well. It is largely safe. There are only few situations wherein we do not give, like any underlying malignancy or any area where proliferation, we are suspecting. Otherwise, desidustat can be given. We give it in chronic kidney disease patients. So his creatinine, because it is nearing 3, So he will require some form of support for his hemoglobin. Desidustat is largely safe, although in the post transplant period, whether we have post transplant patients, we don't have so much experience of using desidustat in the long term. In the short term, yes, it is safe. If it is continued for many months or years, the long term data regarding safety of desidustat in the post transplant period, still we don't really have data on that. Okay, because the drug is relatively new. Unlike erythropoietin, of course, we have been using for many years, decades. Desidustat is relatively new. We have used it in a lot of chronic kidney disease patients. They respond well. Post-transplant period, long-term safety data probably is lacking. So you have to be on close follow-up with your nephrologist.
Okay, ma'am. Thank you, ma'am. And he has another question. His PCR was about 0.56. And one of the nephrologists, not his transplant nephrologist, one of the local nephrologists, asked him to take irbesartan 75 milligram. And PCR got 0.04, and he is well. And he is his question is irbesartan is safer or not?
Yes, irbesartan is safe. It can be given, no problem. Only thing is
Okay, but
creatinine and
another
potassium needs to be monitored. Creatinine and potassium has to be monitored. That's all.
Okay. Another question for uric acid, what is safer, Evustat or allopurinol?
So we are more comfortable with febuxostat because the drug interactions and other things are less. Febuxostat is what we are more comfortable using for uric acid. Yes.
Okay, ma'am. Ma'am, let's take question from the live, and we're taking question from Masum Billavai, and his question is: I had elevated prolactin levels after a stent was removed 28 days post transplant surgery. I was then given the antibiotic meropenem 3 times a day for 7 days. Have any chance to commit again?
No, so that was a most likely an acute infection with stent in place many times. Bacterial infections and procalcitonin is a marker which shows that some bacterial infection must have happened during that time. But that was treated adequately. You don't have any risk because of that infection right now. You don't have. Okay, so you should only monitor for any fresh infections. I'm sure you are more than, I think, 2 years post transplant, right? So that is not there.
Okay, ma'am. Another question from him. Yeah, is it necessary to test MPA levels for 6 hours? Who are taking the medicine to adjust the MMA dose, or WBC count is sufficient or not?
Right. So MPA levels, again, some places like I think CMC Vellore does it routinely. Routine MPA level testing, currently it's not very widely practiced across transplant centers. Some academic centers are doing it routinely for all patients. I personally, I don't do it routinely. In specific situations wherein we are, uh, we are finding some discrepancy in the clinical finding, or patients extremes of weight wherein we are not able to decide on adequate dosage of mmf. These are some of the situations wherein levels are checked. Otherwise, usually it is titrated based on patients body weight, and of course if the counts tend to go down consistently, or we may have to put the patient on a lower mmf dose. So I think there is center to center variation in that. At my center, we don't routinely check for MPA levels.
Ma'am, this question is from all, not only from Mamun Billabhai, and many of us asked this question. Before transplant, he had only taken Hep B vaccine, influenza and pneumonia vaccine is required for transplant patient, and if required, when is the ideal time, and is it necessary to take every year or not? The time schedule, will you please elaborate?
Correct. So, see, if you don't have a limitation, take flu shot every year. So that is what all the guidelines tell. And pneumococcal vaccine, you don't have to take every year. It is once taken, it is valid for 5 years. But there are 2 doses which needs to be taken. First will be a conjugate vaccine, that is PCV. Then 2 months after that, you have to take a PPSV, that is a polysaccharide 23 vaccine. Once you take both, the the protective effect lasts for 5 years. Then after 5 years only, you have to take a booster. And if you have not taken before transplant, I would advise that you please take it. And if you are beyond 1 year post transplant, you can take it anytime. And the early is the best, okay, because it gives protection. And influenza, yes, yearly once is what we advise. And depending on when the new strain of virus comes, usually in our I think it depends from country to country also, whenever the new strain of flu shot is available is when you should take. But if you have had a recent infection, you should give a gap of at least 10 to 14 days before you take the vaccine shot. And now, in fact, we have another new vaccine, that is herpes zoster vaccine, that is Shingrix. So sometimes post-transplant patients we have seen coming with shingles, that is the zoster. Now we have a vaccine even for that. That also can be taken. So once you have crossed the 1 year transplant period and everything is going smooth, if you have had a recent rejection again, I wouldn't suggest that you go for the vaccine, because your overall immunosuppression will be high. If things are stable, it's going smooth, please plan and take vaccine.
If I have had fever or sneezing or cough, then I have to wait for the recovery. And after
Yes.
recovery, I will take it every year. Thank you.
Yes.
So, let me elaborate it to the audience. So, normally hepatitis B এবং ইনফ্লুয়েঞ্জা ভ্যাকসিনগুলো আপনারা প্রত্যেক বছরে নিতে হয় এভরি ইয়ার। কিন্তু যদি আপনার কোনো ধরনের ইনফেকশন টাইপ ডিজিজ থাকে, যেমন জ্বর, কাশি, সর্দি, তাহলে ওই সময় নেওয়া যাবে না, ওই একটু সময় ওয়েট করতে হবে। কিওর হওয়ার কিছুদিন পরে আপনি হচ্ছে ভ্যাকসিনটা নিয়ে নেবেন। এবং ভ্যাকসিন নেওয়ার সময় অবশ্যই
you're talking about hepatitis B, huh?
No. It's for এটা ইনফ্লুয়েঞ্জা এবং নিউমোনিয়ার
ইনফ্লুয়েঞ্জা নিউমোকোকাল।
সরি, এটা মূলত ইনফ্লুয়েঞ্জা এবং নিউমোনিয়ার ক্ষেত্রে এই কথা বলা হচ্ছে। And ma'am, let's take another question from Tanzinul Islam. Ma'am, acha. Before transplant, I had hepatitis C when I am on dialysis, but my hepatitis C RNA was never been positive. I had tested so many times before transplant. Every time viral load was 0. Now I am 2 years post-transplant. I want to know, can hepatitis C back after transplant? Should I have to do RNA test again?
So your antibodies were positive. If I understand correctly, your anti-HCV test was positive, but your RNA has always been negative. So there are two possibilities. One is that you have never had infection and your hepatitis C antibodies were probably positive, and it's been consistently positive, you're saying, many times. Have you tested repeat anti-hepatitis C antibody, anti-HCV? See, so two things are possible. One is, while on dialysis, you had tested anti-HCV and it was false positive. That means you did not have infection, but it just showed positive on a test. If that is a situation, you don't really have a risk of reactivation or anything. But second possibility is that you had an infection somewhere which got cleared on its own. So RNA was negative, but you have antibody. Okay, so in that situation, again, there is a theoretical risk, and probably you should monitor your RNA once in 2 years, or something like that. So it depends what was actually the situation. We'll probably have to go little into the details of it. Sometimes anti-HCV can be falsely positive. It just comes positive, but you never had infection. If that is a situation, you really don't have an increased risk of any reactivation. So yeah, that is it.
And it's related to the question. We have already answered the question, but I'm taking it again, ma'am. It's quite different. And it's from Zahid, 3.5 year transplant. Pneumonia vaccine was taken in 2022 for a lifelong. 1 year later, infected pneumonia and then he been cured. And his question is, will he take the pneumonia vaccine again or not? He already been infected and cured.
Correct. So another important thing what you have to understand, I want to stress upon here is, pneumonia vaccine doesn't prevent you from all pneumonia. Okay, that is very important to understand. The pneumonia vaccine, this he has written Prevnar here, no, Mr. Zahid. So Prevnar and the other one, Pneumovac, what we give, both protect you against pneumococcal pneumoniae. That is a particular bacteria, which is again one of the commonest causes of pneumonia in the community, but it is not the only cause of pneumonia. Okay, so there are different type of viruses and other bacteria which can still cause pneumonia. So this is a vaccine which can prevent one of the commonest causes of pneumonia. So that is point number one. So you developing a pneumonia could have been some other organism. It could have been a viral pneumonia which you got after the vaccine. That is number one possibility. Second thing is regarding revaccination. Yes, if you've taken only Prevnar 13, there is a polysaccharide vaccine, that is PPSV 23, which covers some more strains of pneumococcal. So again, in pneumococcal, it is not one organism, there are different strains of it. So Prevnar 13 has 13 strains, and this is a conjugate vaccine. So once you take the conjugate and then you take a polysaccharide, that is a 23 valent vaccine, there are more chances you will have higher levels of antibody. So yes, what I would suggest is you should go in for the conjugate, the polysaccharide 23 valent pneumococcal vaccine.
Okay, ma'am. One question from Rabiul Alam Munnavai, and this question is not only for him. We have many portion of patients of IgA nephropathy, and they wait to transplant. And what is the risk of getting it again? As far as I know, 40% of patients have the chance to get it again from that previous data. But
Yes,
will you
yes, you're right.
make
You're
it
right.
clear?
So there is high risk of IgA recurrence post transplant. But again, the good part of it is, one is majority of this, whatever statistics tell of recurrence, is the IgA deposits coming back in the kidney. It need not always cause damage. That is what is important to understand. Even if IgA comes back, only a proportion of those patients develop protein leak. And even those who develop protein leak, majority we are able to control with medicines, and they do well in the long term. Only a small proportion actually progress faster, or the transplant kidney get damaged faster because of IgA. So even I have couple of patients with, quite a number of patients post transplant with IgA recurrence who are on follow up. So it is a constant worry, because most of these patients are young and they have had transplant and they see the disease coming back. I understand that it causes a lot of worry, but one thing I would like to reassure is that, one is, your original kidney is the IgA we did not know when it started, whereas in your transplant kidney we know exactly when it is starting, so that we can optimize your medicines. Second thing is, your original kidneys, when it started, you were not on any immunosuppression. So the IgA, the treatment itself is steroid and MMF, which you are already on. So the disease remains controlled, and usually we try to increase the MMF, or slightly increase your immunosuppression, so that the disease remains under control. So these are the points, or the reasons why IgA doesn't behave very aggressively in the post transplant period. And for proteinuria, we try to optimize other medicines, and generally all these patients do well.
One question from me: when a patient got IgA again after transplant, what is the prevention, and if it cured accurate manner, like it reversed like the normal patient?
Unfortunately, as of now, we don't have anything to reverse completely. So IgA nephropathy is one disease wherein lot of research is going on. In the last 2 to 3 years itself, lot of drugs, newer drugs are being studied, and trials are going on. The complement blocking drugs, a lot of monoclonal antibodies targeting the pathway, the IgA nephropathy pathogenesis is being studied in detail. The 4-hit hypothesis, and at each stage how it can be halted. A lot of research is happening, and I'm sure in the coming years we will have better medicines to treat IgA. even in the post-transplant period. So I think it's a matter of time. But as of now, we don't really have anything to reverse it or just make it disappear. But we try to manage it, and it is usually manageable in most of the cases. And I think, as I told,
Is it like the patient got IgA nephropathy after transplant is like a patient, like a CKD patient?
I wouldn't really say that. No, it is not, because as I mentioned, no, in your native kidney, the IgA started many years before it really causing the kidney damage. It had started many years ago. You did not know when it started, and you were not on any treatment at that point of time. That versus now, after transplant, when it is coming back, you are on treatment already. So it is like it is already the treatment is there, so the IgA will not be able to really cause that kind of damage. But despite that, yes, proteinuria happens, and somehow in our Southeast Asian population, Indians, Bangladeshis, Chinese, and all, the IgA somehow is more aggressive than what we see in among the Caucasians, the US, the UK. It is more aggressive for various reasons. Again, that is something which is being studied now, and I'm sure in the next couple of years we'll probably get better drugs to treat
Uh,
IgA.
Ma'am, is it like polycystic kidney disease and that is contagious?
It is not familiar. I mean, it's not exactly genetic, but yes, some genetic predisposition is there. There are families with, there is something called familial IgA, but usually it is more like a autoimmune, right? It is an autoimmune. It is immune mediated. It is limited to kidney. It doesn't cause autoimmunity elsewhere, but it is autoimmune. So some amount of it is in your genes. You have some genetic predisposition, then the environmental factors, and the body's immune response. So multifactorial it is. It is not like ADPKD. ADPKD, we know exactly one gene. If it is abnormal, you'll develop.
It is not congenital.
No, it is not. It is not congenital. It is not. So even if, let us say that, see, ADPKD, if one particular gene, there is this PKD1, PKD2, there are specific genes on, let's say, chromosome number 16 and 4. So if that is gone, you are going to develop ADPKD in your lifetime. So that is how it is. Whereas IgA, it is not like that. There are some genes, if it is abnormal, you have higher risk. But for all we know, you may not develop. So a lot of your food habits, lifestyle habits, your the exposure to different environmental triggers, environmental antigens, the antigens in your food, it starts in your gut. So the IgA, abnormal IgA, starts in your gut, in your intestines, and then it goes in the blood, and then it goes and deposits in the kidney. So that is how it happens. So a lot of environmental factors, everything comes into play. But still, we don't really have one thing we say that you do this, you will not get IgA. It's not like that. Yeah.
Okay, ma'am. Thank you. Not is clear. Most probably এটা আপনাদের সবার কাছে ক্লিয়ার ম্যাম যা বললো। এরপরে কোনো কোশ্চেন থাকলে পরে বলতে পারেন। তারপরে বলে রাখি ম্যাম যেটা বললো যে সাধারণত যাদের আইজিএ থাকে 40% চান্স থাকে ট্রান্সপ্লান্টের পরেও সেটা রিপিট করার জন্য। এবং আইজিএ যে ট্রিটমেন্টটা এটা অনেকাংশে আধুনিক ট্রিটমেন্ট এবং মানে রিসার্চ হচ্ছে এর থেকে ভালো ট্রিটমেন্টের জন্য। আইজিএ হলে পেশেন্ট সিকেডির মতো হয়ে যাবে এমন না, ইটস ট্রিটেবল and long time survive করবে। Is that it, ma'am?
Yes.
Yes, ma'am. Before ending, ma'am, we have a question. Most probably it's a vital question. It's about tuberculosis. Okay, ma'am. What is the chance of the transplant patient of getting tuberculosis? And if I got tuberculosis, is it treatable? And is that contagious or not?
Yes. So tuberculosis, again, it is still very common among us Indians, and I'm sure in Bangladesh also. And yes, post-transplant period, tuberculosis can come anytime. So we have seen patients coming 2 years, 3 years after transplant with tuberculosis. So it can happen anytime, because we are all exposed to tuberculosis right from our childhood. The bacillus, the TB bacteria usually remains latent inside the body, and it can get reactivated, or sometimes you can get fresh infection. Is it treatable? Yes, it is very much treatable. Tuberculosis, if diagnosed at the right time, it is completely curable. So it is important to take treatment. It is a relatively prolonged treatment. For few months you have to take it, but please complete the treatment, because if you stop midway, then the organism will develop resistance, then a lot of complications. If diagnosed with tuberculosis, please do not hesitate, take treatment and complete the treatment as advised. Next question, is it contagious? Some forms of tuberculosis, yes, contagious, not all tuberculosis. So the pulmonary TB, when the tuberculosis comes in your lungs, you're coughing out, that yes is contagious for a couple of weeks till you start the treatment. I mean, after starting the treatment also, for a couple of weeks you remain contagious, yes. But there are a lot of other areas of TB lymphadenitis is very common again in our post-transplant patients coming with some node, we do FNAC, it comes out to be TB. It is not at all contagious. Tubercular lung effusions, pleural effusion, diagnosed as tubercular pleural effusion, again it's not contagious. Bone tuberculosis, musculoskeletal TB, it is not contagious. So it is a pulmonary TB which is contagious to the immediate contacts, but it is very much treatable and you have to take complete treatment.
Yeah, ma'am. After transplant, we have to go back to work and to have to mix with the common people. And if the people, if many people or some people have tuberculosis, is there any risk for me to get infected?
Correct. So once you cross the 6 months to 1 year period after transplant, if you have good nutrition, you're on a balanced diet, your risk remains, yes, elevated above the general public, but it is not very high risk. You have to take precautions. If you're going into a crowded place with no ventilation, with very poor ventilation, you have to wear mask. So if it is a well ventilated open air area where you're going, your risk is less. I mean, as compared to you going into a crowded, ill ventilated area. So you have to take your precautions, but that shouldn't prevent you from living your life. That is what I would say. If you have beyond first year transplant, you should not keep worrying about infections. And some people don't go to work, sit at home fearing infection. That is not what you should have. Transplant is something to get you back to normal life. You have to lead a normal life, you have to go to work. In fact, you are allowed to travel, you're allowed to play sports. You have to just take your precautions and go ahead with your normal day-to-day activity. Rafi, I think you're muted.
Am I audible?
Yes.
Another question from all: if I got proper nutrition and if I get more antibody antigen through food, and if I got well nourished, is there any chance to get chronic antibody mediated rejection or not?
No, it doesn't happen that way. So immunity is a very, very, very complicated subject. It is not that if you get good immunity, you will reject your kidney. It doesn't work that way. Okay. So good immunity, well nourished, it will only protect you against your infections. Okay. So the rejection, there are different reasons for that. Your, how do I say? So anything that will lead to sensitization. For example, you should be exposed to that particular antigen. You have a kidney from somebody else and your body is already exposed to that antigen, let's say 1-2 years. Your body is seeing that there is a different. Okay.
Okay, ma'am.
Immunosuppression after a period of time. Am I audible?
Yes, ma'am. Audible.
Yeah. So after a period of time on stable immunosuppression, when things go smooth, your body also develops something known as immunotolerance. There is a term called immunotolerance. That means, yes, the body knows there is a different organ there, but it is also developed some kind of tolerance to it. So on stable immunosuppression, on stable things, usually it doesn't happen. So the problem happens when immunosuppression, overall immunosuppression is low. We call it under immunosuppression. Okay, under immunosuppression, slowly body will start forming antibodies. So it is a very fine balance.
Nutrition or malnutrition can cause infection also.
Yes. So infections are risky. See, infections, when you get infection, in fact, certain infections can trigger rejection. That is something which I did not mention. Certain viral infections, for example, CMV infection itself is known to predispose you to rejection. Post CMV infection, rejection rates are high. So viral infection especially can modify your immunity in such a way that you can reject a graft. Okay, that itself. And secondly, when you get an infection, we naturally have to reduce your immunosuppression. That will predispose you for rejections. So preventing infection is very, very important. Okay, so that is the final message, that you have to prevent infections, and overall nutrition precautions, following your medicines, watching for symptoms, regular follow up, all this is important.
Thank you, ma'am. I didn't take some question because you have answered from the beginning all of the question from us, and most of us were in most of us were cautious about pneumonia and the influenza vaccine. You have cleared it all from the very beginning, and most probably all of us have understand what you are talking about. And ma'am, now it's about 2 hours. Thank you, ma'am, for
Yeah,
giving us that much time. Uh,
no problem. And just one thing I would like to tell you is that whenever you're taking vaccine or anything, always try to consult your primary transplant physician. That is something I tell, that once you're transplanted, you're like married to your transplant physician. One of my senior colleagues always tells that you're married to your nephrologist. So basically you have to be in regular follow up.
yes,
Even
ma'am.
if you're planning to take let's say a vaccine, if you had some infection recently, your doctor will be able to guide you better. So don't just go by so today's talk is for general awareness, to make you more aware of the things. But just don't just go and take your vaccine tomorrow because I have told. Don't do that. Don't do that, because your overall, what is your status, what is your immunosuppression status, lot of things vary. So please consult your nephrologist before taking a vaccine. Okay, don't just go
Okay.
and take it on your own. That is very important. Again, an important message. I hope I'm clear on that.
Thanks a lot, ma'am. And thanks from our group, and every of us loves you. Ma'am, I will request you after 1 or 2 months to come again. Hope you will accept our request.
Sure, sure. Always happy to always happy to interact with your group.
Thank you, ma'am. Thank you. After 1 or 2 months, we will request you to come again. And
Sure.
thanks again, ma'am, for being with us. Thank you, ma'am.
My pleasure.
Okay.
Bye bye.
Okay.